So I just want to introduce myself. My name is Sarah Storhoff, and I work here at Seattle Children's, and I've been on the planning committee for this wonderful conference that you guys are all enjoying today. And I have the distinct pleasure of introducing our next topic, and our presenter here, Nikki Banks, is a colleague of mine who will be talking with you all about care coordination and some really significant work that she has led this last summer and fall regarding care coordination in our back offices. As you all know, we're all very busy, and here at Children's we have over 30 or so subspecialty clinics, and she has really led this work to standardizing our school forms and what that process looks like to you all. So with that, I will introduce you to Nikki.
I know some of you. I've met with a bunch of groups of nurses and nurse managers. I've worked closely with Sammy. So for some of you, this may not be new, but I was asked to focus today on what the process of standardizing the care between the specialty clinics looked like and what that meant as a downflow to school nurses and the impact that it has there. So that's why we're here for the first part of the presentation today. So we're going to specifically talk about school forms today. Sorry, objectives, my apologies. I don't have any disclosures to make. I have no interest in anything here. So for the objectives, we just want to talk about what the driving force behind the standardization process was, and then how HIPAA and FERPA work together to support the care of these children. So just to start to understand volume and the amount of children that we're talking about, our annual patient visits are over 400,000, and of that, over 350,000 are in our outpatient clinics. On main campus, we see 200,000 of those patients. And of those, so as Sarah was mentioning, we do have 22 specialty clinics with 8 subspecialties and 11 different locations. And of that, it's staffed by 210 nurses, 80 MAs, and then 15 additional support staff. So for the purposes of speaking of school forms, I'm going to focus on the 97% of our population that call Washington State home, because I really only have focused on Washington, even though we do have 3% outside. So Washington State schools, I was amazed when I found out there's 295 school districts, not even counting independent schools within the districts. They educate over 1 million students per year, and in 2017, and this information was given to me from Nicole Klein from the Office of the Superintendent of Public Instruction, there was a voluntary assessment done, and they reported that there was 84,000 medication orders received. And given that it was a voluntary assessment and not mandatory, we know that there's a big gap of information that wasn't received. And that does not include treatment orders for things like cathing or G-tube care, things of that sort. And so in Washington State schools, there's over 900 school nurses that range everywhere from LPN to nurse practitioners. And there are only 3 revised codes of Washington that reference or dictate medication administration within the Washington State schools, and they're listed there. What it came down to when I started was I had to go around to all the specialty clinics and ask them what are their pain points and what can I do to help standardize and streamline the work that they do to improve the care that they provide to the patients we see. And there was 2 things mentioned, and one of them was school forms. And so then began the journey of trying to figure out, what do you do? This is a huge volume of work and a huge volume of children that we see, and what is best. And so I worked with Nicole Klein and worked, and it took about a year to standardize one form. And yeah, so, but after the first one, things became easier, but it took about a year to standardize one form. But so I'm going to go into a couple of details about HIPAA and FERPA and how they work together, and then we'll go into a little bit more about the forms. So there's a constant conversation about why are staff nurses here who are bound by HIPAA not able to speak with school nurses who are bound by FERPA? And so HIPAA is the Health Insurance Portability and Accountability Act. And HIPAA binds anybody that bills insurance companies for the care that they provide. That's us as a medical institution. FERPA is the Family Educational Rights and Privacy Act, and it applies to people who educate at the place where the care is provided and who do not bill for the services that they provide. So if someone at a school-based clinic bills insurance for the care that they provide, they're bound by HIPAA and by FERPA, and then it's full disclosure at that point. There are a lot of different interpretations on what HIPAA and FERPA mean together. So I can only speak to what it means for us here at Seattle Children's Hospital, what we've instructed our nurses to do when speaking with school nurses, and the point that we've taken, but we're very pro-school nurse. And so it had gone to a point where well, you're not bound by HIPAA, so I can't talk to you. And so it's all about bridging that gap and making it a more of an us than a me and a you. And so that was how I got into the HIPAA FERPA and how do I make it work together. So again, this is the example that I gave about billing Medicaid and how that applies for HIPAA and FERPA. So IDEA is the Individuals with Disabilities Act, just so you know. This is a very important document for you guys to have and to understand. This is the information that our staff nurses are given to communicate with nurses who are bound by FERPA. And so for an example, if an institution who has nursing staff, a clinic nurse in the community calls us, and they're bound by HIPAA, they're caring for our patient, the information that they need, we have, and they need it to care for their patient, we can speak with them because it's continuation of care and there's no issue. But because HIPAA and FERPA are different, we have boundaries that we cannot cross because of the law. And so this document indicates when you can speak with across HIPAA, FERPA, what you can share, what you can't share. And what this really boils down to is if a family brings you a document that they've had filled and signed by a provider here at our staff, you are allowed to speak with our nursing staff regarding the information within that document. And this is independent of having an ROI. So if a family brings you a medication administration form and it's been signed, you can call and ask clarifying questions about the diagnosis and the information related to that form, but we can't give you any additional information. Same thing if they brought you an asthma action plan or a seizure action plan and you need clarifying information, we are allowed to give that to you without an ROI on file. It's an implied consent to speak with you about that form. But for anything else, we do have to have an ROI to have a general conversation. And then the conversation gets a little bit trickier in that, well, why can't they just sign our ROI and we send it to you? And again, it's just not that simple. There are certain pieces that have to be included in an ROI for Seattle Children's to find it legally binding. And unfortunately, a lot of the school forms that are in circulation now try to combine forms with ROIs, and then it's basically invalidated. So we do want to be able to accept the ROIs that are provided by schools. So if you have questions about if your ROI meets the minimum required elements that we need, you guys can email privacyquestions@seattlechildrens.org and ask them, and or go online and download our ROI and have the families fill it out and fax it to the clinics that you're questioning. Another question that we get asked a lot is, or that's been brought up, is that, well, you already have an ROI on file, and then our nursing staff is asking for another one. I apologize. That's an oversight. We're working on it. And in those instances, it's just good to have an open conversation because everybody just wants to protect themselves and make sure that they're not speaking to someone they can't speak to and that they're not giving information to somebody who shouldn't have it. And you know, all of these rules and all of these laws are always made in response to something that happened at some point to protect individuals. And our nurses want to help. They don't want to get in trouble. So this is how we have figured out how to bridge the gap. And this was made with our legal team and with compliance, so the information in here is solid. But again, if you have questions specifically about the information contained in your ROI and or if it's acceptable, please just email privacyquestions@seattlechildrens.org. So what is this? Yes? It's not, I don't think it's posted on the internet. It should be in the handout I gave you, and I can see what I can do about getting it posted. I just don't know where it would live because it's a compliance document. I don't really know. Is it? Okay.
Could you send it to the group that's here today?
Absolutely. Absolutely. Can you help me remember that? Okay. No, and because and the questions that are contained within that handout are questions that our staff nurses said, this is what school nurses need when they call us. These are the questions they ask. And I said, well, let's preemptively just answer all of the questions that we can, yes or no. Can we help you? Can we not? Do you need an ROI or do you not? And so that's what's in that document is just a clear yes or no. Okay, so I've talked about lots of pieces. And so putting it all together, 1 million students per year with 350,000 visits here. And it is an estimated or a perceived growth of 10% a year. So we're not having less kids. No less kids are getting sick. You know, we're saving babies younger. There's more children who need medical care and who go to school in the community. Last year, we sent over 50,000 letters from our main campus alone. In that was a huge bulk of school forms, but that's not just school forms. It is, all the documents that other companies and other institutions outside of us want, FMLA paperwork, parking permits, everything. And we have a huge upswing in these requests every August and September. I don't know why. And, and of course, always that huge percentage of families that wait and the very last day, and school is started, and now it's an emergency when their child has had seizures their whole life. I get it. We get it. We all know the pain. Okay. So I know you guys feel the pinch in the same way we feel the pinch in that the forms are needed. The forms have to be filled out and signed, and they have to be returned. But there's only so many people here who can fill out the forms and so much staff in a given day. With the variability in all of the forms that we got from all of the schools, we just couldn't maintain current state. Every form had a different rhythm with different information. It required different elements and signatures, and none of them were the same. I think there was a couple within Arlington School District that were the same between schools, but within a district, they're not the same. School to school, from the elementary school to the junior high school, they're not the same. So if you think about all of the school districts, 1 million schools, 350,000 clinic visits, and everybody has a different form. And so at some point, the dam had to break. And I was here for that. So, and so what these numbers say to us is that there's an absolute need to standardize. This is a huge volume that we wouldn't expect anybody else to do. You wouldn't expect us to do if you knew how big the problem really was. And so standardization is not just better for us. It improves the efficiency. It improves the care that's being provided. If you get the same letter 40 times, you know how to read it. You know where the information you need is in that document without all that excess variability. And it's the same for us when we're filling it out. And now the way that they are made, they are contained in the patient's electronic medical record and available on the portal for patients who do not have a solid home address. And I just want to say Nicole Klein was very passionate about that because of the large homeless population that don't have a home mailing address for these forms to go to. So I would like to give credit where credit is due. I had nothing to do with the diabetic care plan or the seizure action plan. Those happened long before I was here. But I have standardized with OSPI 5 forms. The medication administration one is the one that took a year, because of the vast variability amongst the forms that existed and trying to incorporate all of the elements that I could that were consistent across as many forms as possible. The asthma care plan, the severe allergy care plan, the clean intermittent catheterization and self-assisted catheterization form, and tube feeding forms were all forms based upon examples Nicole Klein herself gave me. I did not engineer those, but I did take over for formatting, and we got content experts for all of the specialists that work in those fields to validate the information that's embedded within them to make sure that best practice was being observed. And there was huge discrepancies, and so I was really glad that we were able to do that because none of them were up to date with the most current best practice information within those specialties. And so, sorry, that's what that already says. So what does this mean for you guys? Continue faxing and requesting, calling, whatever you have as you have. If it's most comfortable for you to fax a request on a form that you know is not going to be returned to you, that's fine. If you just want to fax on your letterhead and name the students that you need forms for, that's fine as well. The forms are engineered to be sent directly to the family at the home mailing address once they're signed. And this is with the intention because there is a release of liability embedded in that form with the RCWs for the patients and their families to sign, releasing liability for the medication administration at school. So it's a whole bunch of items all rolled into one. And if we have an ROI on file and it's current, we can fax it directly to you, but that has to be a specific request. We don't know, a request of a form does not automatically mean you're requesting it to be sent to you, so that's just additional communication. And I think one of the huge benefits is that, so the seizure action plan, the diabetic care plan, and then the 5 new forms are all available on the portal because we know these families lose these things. And it's a signed version that's on the portal and only the most current one, so they won't get bogged down with, oh, this old one or that one. And we added some elements in them to say such things as this form is valid for the entire school year to include summer school without a specific date, because we don't know what the dates are. The districts are different. Each school is different. And so we can't say, oh, this is good until, August 15th. I have no idea when your summer school programs end. So as long as the child is in your care and that new school year has not begun, the form is valid. And it's for all hours that the child is under the care of the school, because we needed to be broad in order to best serve the kids. By no means is this perfect. I've gotten a lot of feedback. Nicole Klein sent me an email that amounted to 4 individual pages of feedback from you guys about the forms. I am taking it all in. I am seeing what is valid and what can I do for you guys. Obviously, everybody's opinion is important, but not everything is practical, nor can I incorporate 4 pages worth of feedback into these forms, but I'm going to do the very best I can. And that once the forms are revised, revised paper copies will be provided to OSPI to do with as they wish. These are blank paper forms, can be used by anybody. They're nondescript. They do not mention Seattle Children's Hospital. Only the ones that come from our electronic system reference Seattle Children's. Everything else is for general purpose use. So just a quick recap. As of December 15th, this is the volume of letters that we sent just from the start of the school year in September. And so it's a huge volume, and if you imagine just in that short period of time, and this is not with 100% adherence to the new school forms. All of the clinics haven't taken them on. All of the surgeons don't use them. There's a huge gap of people who don't. And this was just with our initial rollout. And so that's huge. That's a huge amount of standard forms that have been sent out, and not without problems and not without issues. But it's a baby process, and it's coming around and it's growing. And so, like I said, now our goal is to improve the process that we have now changed. Okay, so this is the end of the first presentation I have, and so now it's time for questions before I go into the next one.
Let me make sure we get everybody's questions on.
Do you have an example of any of your forms?
No, I did. Oh, well, the next one is a asthma action plan in action. So that's.
We're gonna do a little question and answer period now, and then go over the asthma action plan next with questions. So we'll take one here and one there.
Hi, I really appreciate standardization, love it in all aspects. That's a great thing. My confusion, though, is that I've never actually seen a medication administration form. I get really garbled information when I have the family fill out an ROI and send it to you, and then several weeks later I get something in the mail that doesn't answer the question and is not a form allowing me to administer a medication. So what I'm confused about is why it would seem much more efficient if within your medical record system, I know it's not Epic, I'm not as familiar with whichever one it is that you guys use. Why is, when a physician writes a prescription for anybody aged 4 to 18, why don't they just automatically crank out a form that allows them to give the medication at school? That would seem the most efficient.
In a perfect world, and we would also have ROIs on all of our patients. I get it. I get it. It is not an inherent part of what people do for a variable amount of reasons. Some of our sickest kids are not integrated into the school system, and so yes, in a perfect world that would happen, and I completely agree. And some of the clinics have great processes for that, like the endocrine clinic and the neurology clinic. They know if a patient comes in, they need a new diabetic care plan and a new seizure action plan. But that's because their whole system is based on that, and not these other clinics that just, not every single one of their patients is on medications. And
Most of the time about the EpiPens, it's those hundreds and hundreds of damn EpiPens that I can't hunt down and I can't get down to the family and
Okay.
minor to everybody else.
no, and Epi is a big deal. So I'll see what I can do to come up with examples, but I want to make edits to the forms based on the feedback before I send out paper copies. But once those are available, I will get a hold of Jennifer to email all of you with the finalized paper copies, which should happen soon. That's my next project.
I just had a quick question about expiration of the ROI. Does it expire?
It has to have a date on it, but what that date is it can say 2030 on it, but it's only valid for the specific school that it's written for. So if it's written for an elementary school in Kitsap County till 2030, it's good there, but that kid is not going to stay there till 2030. So it is flexible. It doesn't have to be 1 year at a time.
On the patient portal, does Children's have a site where parents can go for directions to access it? And secondly, with that patient portal, can they get records for a clinic visit or only the standardized forms?
There is a lot on the patient portal, and I believe that they are trying to sign them up when they're in clinic to ask them, because that relieves a lot of burden on a lot of people. Do you know specifically what's on the portal, either one of you? Oh, sorry, someone has an answer. Oh, yeah, Susan, please.
Hi, I actually work here in the IT department, so I kind of know. So to sign up for the patient portal, if you go to our seattlechildrens.org, there is a link for patient portal sign up. So the patient's family can go in there and request how to sign up. And what was the second question? So our patient portal right now, we do not put out clinic notes. So they're usually discharge forms, and we have we kind of pick and choose kind of what are out there. In the future, we are really planning on doing an open note concept, which is putting out pretty much everything out there, but that's to be decided. For you to request clinic notes and things like that, it has to go through our HIM department right now. So you can't get everything through the patient portal.
Can you get that one?
Medical records, yeah.
Can you get that question there, and then I'll do this one?
I just wanted to share, Pierce County Medical Society creates all the forms. So if a healthcare provider does not have access, like a parent comes in and says, my kid's going to this school, they can download it, complete whatever they're writing for, their asthma, medications, that type of stuff. And it's available to anybody. So you can go Pierce County Medical Society, go over to, I think it's forms, drop down schools, and there's all the examples, concussion, all of those forms are there. So if you want to look at some ideas,
thank
Pierce
you.
County Medical Society, which all the providers in Pierce County are aware of.
Oh, okay, thank you.
I'm sorry, you already explained it, but I'm not sure I understood this HIPAA FERPA thing. Because we also are under HIPAA, right? Because of the Medicaid billing that we do. So why can't we talk to each other?
If you're bound by HIPAA because you bill Medicaid, we can speak with you.
But there is no way you can verify that, right? So
We can verify by an institution. So where do you work?
at Kenmore Middle School in the North Shore School District, I mean, we all do pretty much bill Medicaid for one reason or the other.
Right. And this is where it gets very gray.
I
So
know, that's-
if it's fee for service and you bill for the services that you provide when you see the children, then it's bound by HIPAA.
Oh, yeah, it's by student, per student. Okay.
We're having a hard time hearing everybody, so if you can repeat what she said if possible.
Yeah, she was just stating that it's hard because not every child is paid for by Medicaid or the other way, vice versa. The only thing I can offer is that this is the interpretation that Seattle Children's has for the HIPAA FERPA confusion, and that is what it is confusion. It is very gray, and we all get down to the nitty-gritty and pick it apart and read it to be something different. And so this is best case scenario from Seattle Children's Hospital, so at least we understand where each person is coming from and what we can and cannot share.
Okay, thank you. And then my other question was, what if there is a life-threatening issue? We can still call.
Absolutely, we will provide
Right?
you with
This is
information
always-
over the phone for any life-threatening
Right.
issue at any
Okay.
time, yeah.
Thank you.
I'm assuming that the patient portal, they can print out these standardized care plans.
Yes, if they've had one filled out and they've lost it, they didn't get it in the mail for whatever reason, it will be loaded on the portal.
Okay, then my next question is there a way to navigate that, the rules about if they're 13 or older? Like, will parents still be able to get in there and access those things, or will they be locked down to the parent?
I'm gonna refer that one over to Susan because she's been working on that project directly, so, and I see her eager to help.
Yeah, so we actually have a very, so for teenagers, a teen portal, we ask that when the teenager and the parent come in, we ask the parents if they can sign a consent to allow the teen to have their own portal. So the teen portal, for the teen, you can see everything. But for the parents, it's a very limited view. They could only really message the providers, and they really can't see anything else. So the teen has all of their data, but the parents have a very limited view of the portal when they turn 13. So we have
Nonverbal
a
special
special,
needs.
yeah, we have a special case for that, and
Yeah.
we do have our health medical records department who allow the parents to have a team with cognitive impaired, those special cases. So the parents of those kids can have full access, but it has to be signed and approved by the physician that they can do
The
that.
parents can't just say,
Yes.
well, my kid can't take care of himself,
Exactly.
I'm gonna do it. It has to be validated by a provider.
So EpiPen forms, parents can't print EpiPen forms for teenagers, or they can?
I think the teenager would have to. If they've signed up for the portal and they have teen access, then the teenager would have to print it if they have one.
And then we have to get the parent to sign the form that the teenager has to print?
Can you say that again?
I understand there's a huge complex relationship between, and especially for the families with the parents who can't get a hold of them and you can't hunt them down and you can't get them in front of you. And I have no way to cover that ground. By making these things available on the portal, we felt like we were helping to bridge some of that gap in that if the parents don't bring them, don't have them, you have that form. And, you know, you're always gonna care for a kid who's having a life-threatening crisis anyways. It just gets a little stickier, but I have no way to bridge the gap. The parents that avoid you guys are the same parents that avoid us. There's no, they're not any different for us, and so I don't have any better information.
But I thought that the 13-year-old stuff was about sexually sex and mental health and that kind of thing, and I don't think of EpiPens as sex and mental health. So why wouldn't that be on the parent portal?
There's just confusion about what is considered private and what is not, and then if you have a 13-year-old who does have an EpiPen and they can print that out, I mean, there's just other responsibility. There's responsibility of parenting and responsibility of these other things. And the transition to having the teen portal has been complex and not without its issues, and so we are working out those bugs. And I mean, that's a question Susan and I can take back and say, why can't these life-threatening forms or these medication administration forms that have nothing to do with mental health and sexual health be available on the portal? And we can ask that question. But honestly, this is the first time I'm hearing it. So.
Why we can't pick and choose some of these, and we really tried hard because we know we want the parent to be informed, our providers to be informed with everything, but unfortunately the current state of the EMR system, we can't pick and choose certain meds, certain things, is medication or not, all medication or nothing. So that's kind of the limitation from the system side. So hopefully as the technology grows, we're able to we are moving over to Epic, but I'm not sure if that's even doable in Epic.
Susan, do you know what percentage of kids we've had signed up for the teen portal or what the current number is?
So we started, we did the teen portal starting mid-September of this year. So we've been live with patient portal for over 3 years, but due to the complexity of the teenage population, we just went live in September. And we have about 500 teenagers that have accepted. And the acceptance rate for teenagers is actually significantly higher than the parents. So I think the teenagers are really, they don't want to talk to anyone. They want to be able to use their phones and apps. So it's a really good sign. And I'm hoping that, things are going to we're going to get more participation.
All right, we're going to have to move on to the next presentation or we're going to completely run out of time and nobody wants to stay late. So now this is taking all the information we've had about the standardization of forms and what that means for you guys. This is going to be a case presentation with an example specifically to the asthma action plan, how to read it, how to use it, how to love it. I have no conflicts of interest. I have no commercial support, children's. So the objectives are to distinguish between the salient parts of the asthma action plan and how to apply the information in the ambulatory care settings. So a quick review, because who doesn't love a good picture? Asthma is a chronic inflammation characterized by episodic airway obstruction, and the key takeaway point is that it is reversible. It's reversible. So 7.1 children in the United States currently have asthma, and it's the most common serious chronic disease of childhood. It can have a significant morbidity if it's not taken care of properly in the scar tissue and the issues that they have from suffering frequent asthma exacerbations. And every day in the United States, 36,000 children miss school due to asthma. That's huge. And currently, we have about 1,000 asthma patients a year that see our asthma specialists, but this is not to be taken without that most kids with asthma are seen at their primary care provider and cared for there. These are children who have special and/or extenuating circumstances or who just specifically need a pediatric pulmonary specialist to care for them. And so what we do is for children's, and this is pretty typical for most asthma care plans, is to take the stoplight approach in that green is every day, you're healthy, you feel good, everything is fine. Yellow, you're having some symptoms, you're having a little bit of difficulty breathing, you can take your inhaler and you're fine. And red is really, you're struggling to breathe, you're struggling to stay awake, you're struggling to be alive, and you need a lot of help. So the standard approach to asthma management, like I said, all these forms were, well, this form specifically was based on a form that was given to me by Nicole from OSPI, and I took it to our pediatric pulmonary specialists, and we reviewed it, and we found that with the algorithm that was on the existing forms that we were reviewing, if you gave the maximum dosing of, it was 2 to 4 puffs every 5 to 10 minutes, and it had all these steps on it, you could end up giving a kid almost an entire inhaler, effectively overdosing them on their albuterol, which is not effective, and you're then wasting very valuable time in treating them and getting 911 involved. And so when we took the form and reviewed it and added and embedded the information for best practice, we took away all that variable information because there is current existing standard best practice treatment for asthma. And so these are this is for all just general asthma kids. There are children who have exceptional allergies that have asthma exacerbations tied to their allergies, and we kind of cover that a little bit. But for the most part, it's just there's standard protocol for treating asthma now. They know what works and what doesn't. So, so again, we followed that green, yellow, red format of the stoplight because it creates a great visual. And when children are inpatient, they get a handout that has a lot of information on it with a lot of visuals, and one of them is a stoplight. And so we wanted to keep with the same theme. What does this mean for school nurses? So again, the request can be made as always. You don't have to fill out a special form or anything. You just ask us for an asthma action plan. And the form that we return is going to be the customized standard version of the form, meaning that while there's standard protocol, each kid is an individual and they do have variability within the care that they get. And it will also follow the green, yellow, red format. But what we also learned was that green, yellow, red does not transfer to black and white very well. So it says yellow and red, but it's not in color because our forms don't print in color and none of the coloring carried over. So it is black and white, but in what we call the green, yellow, red format. Yes, ma'am?
So when we request, we don't have to have a parent signature because it's embedded in, it's okay. We can just request an asthma care plan for the student. We don't have to send you their permission to ask for that.
No, you can ask for whatever you want. We will mail it to the family at their home address.
That's what, okay. So
Yes,
it'll come from the
and
family.
then the family is responsible
So it
to bring it
doesn't
to you.
come directly to us, it goes to-
Right,
Okay, thank you.
right. And that is also to help in the part where sometimes these families are just MIA, but they see their kid, they can sign the form, they can stick it in their backpack, it can get to school to you. There's just all these little itty bitty things that we've tried to do to help bridge that gap, but again, I can't speak for the families that just disappear. So then the whole next part of this is just going to be reviewing what the asthma action plan looks like, going over the points on the form, and then we're going to go over a case presentation to see how to actually use it. So this is what the form will look like. It does not have the pretty Seattle children. So this is the view from inside the system that I see, but not how it has like the Seattle Children's logo on it and stuff like that. And so it'll say the name of the form at the top, and they all pretty much will have the same heading and have but a different title. So it'll tell you the date of the plan, so that's the date the plan was created. And then there's that sentence, the medication is valid for 2018 to 19 school year to include summer school, again without specific dates because we don't know what your specific dates are for your individual locations. It is going to have the general school information, but again, if the family if the family requests it and they don't know the school information, it will be left blank, and it does not make the form invalid. It just means lots of families actually don't know what school they're going to pick for their kids and say, I know they have asthma, I know I need this form, but I don't know where they're going to go. And so that part is left blank. And the grade level is left blank. That's for you guys to fill out. Age does not equate grade for us, and so we don't always know what grade children are in. And so asthma severity can be between, mild, moderate, or severe. And so that's what severity indicates. And then usual symptoms, while there are a handful of usual symptoms, each child does present differently. So this child's symptoms are, oh, my little dot is not where it's supposed to be. Coughing and asking to use the inhaler. And there could be a myriad of items there. And then this is specific to my little... Jennifer?
I don't know.
No, let's just, okay, I don't know. Okay, so hold
don't
on,
know
let me
about
see
your
if I
dog.
can, no, the
Here's
whole,
a pointer.
it's all messed up. Okay, we'll just do that. Okay, so for triggers, everybody's triggers are different. This one just indicates that respiratory colds, pollens, animals, sometimes it's just air, bothers them. We did receive feedback that home controller medications was important because nurses at school want to know what is their baseline maintenance medications for asthma at home. So that's why that information is there. That will be different for every child. Some of them will have 4 medications listed on the form. And then here, is there any severe allergy? And this is just because of the relation of airway issues, breathing, and severe allergies. And it says yes. So if yes, There will be an additional severe allergy form attached. We're still working on the implementation and encouraging everybody to use it. But again, we're in the infancy and it's still growing. So let me see where this dot's gonna go. Okay, so, oh my gosh. Okay, so quick relief medication orders. So when it says this medication qualifies as a 72-hour disaster preparedness medication, that's hard-coded. It will be on all of these forms because every kid with asthma needs to have an inhaler on campus in case the world falls apart. Anybody can have it, even if they have mild intermittent asthma and have never needed their inhaler, they still need to have an emergency inhaler on campus because you never know when that moment is going to happen, and obviously they need it because they have an order for it. And then, so right here, it tells you that the medication name is albuterol. Everybody, there's a few standard medications. It is typically going to be albuterol. A couple kids respond better to other medications. That would be indicated here as well. The medication side effects for all of these medications are the same, and they include restlessness, irritability, nervousness, tremor, irregular heart rate. Those are just, you know, they get hyper. And then the form goes in. So green zone, because we know green zone is normal, they're acting normal, everything is fine. We didn't actually include green zone in here because you don't need to know what to do when they're feeling fine. They're feeling fine, they're not in your office, they're not seeing you. So when we get into yellow zone, the asthma symptoms here are very general. Just because we know what their usual symptoms are doesn't mean that every time they present to you, they're going to present with their usual symptoms. So we gave general information about asthma symptoms in this zone would be coughing, wheezing, chest tightness, difficulty breathing. Whether that child usually presents asking for their inhaler may not happen every single time. Sorry, let's see where the dot takes us now. Okay, so in the yellow zone, I have no idea where the dot's going, I just need it out of my way. In the yellow zone, asthma symptoms. And so then here again, it will be standard to give 2 puffs of the quick relief inhaler with the spacer. And I'm not sure what information you guys have, but giving an inhaler without the spacer is almost not effective. They get like 10% of the medication when they get it. So to give it without the inhaler is to almost not give it. Yes, ma'am?
We have the information, we just don't have the spacers most of the time.
Okay. Yeah, and now nurse practitioners can't write for the DME orders, and now spacers are DME. So bigger problems. But just know they need to have really good technique, and they need to be coached really, really well when they're using an inhaler without a spacer, because they do not get the same amount of medication that they should be getting. And so again, standard information is after the 2 puffs of the quick relief inhaler with the spacer. They can have the inhaler again if their symptoms persist. You need to wait 20 minutes. And then they can have the quick relief inhaler again. And if they have no improvement after the repeated dose, it's time to go to the red zone. Okay, so they have the inhaler, you repeat it, they have it again, and they're still not improving. Then you're saying, okay, I've already given them 4 puffs. It's been over 20 minutes, and now we're going to go to the red zone. Until symptoms resolve, though, it is important, and this is a standard part of the form, is to say, restrict their strenuous physical activity. No, you can't go to recess if you're still having a hard time breathing. No, you can't go back to class. No, you can't go do these things. You need to sit here, because you know, they say, oh, I'm feeling a little bit better. I need to go. I'm gonna go play. No, sit down, stop, like take a breath. And so, and after, once they're out of their exacerbation and they feel better and they can go back to class, they can have their inhaler up to every 2 hours after that, per their standard dosing. Sorry, let's move the dot.
Sorry, is this the form that's in our system and it would look different printed, right?
This will look a little bit different printed, but it follows the same format.
Okay.
Yeah.
They'll have their name somewhere on there?
Yes, yes. This is a test patient, so I just didn't even put the fields in there because I didn't want to share patient information. Yes, ma'am.
So we have your 2 puffs quick release inhaler with spacer. So are we going against the medical order if we are doing it without the spacer? Should we put is recommended on there?
They never order an inhaler without a spacer. Whether, right.
But just for home.
Yeah. I'll have to ask. I didn't know that you guys weren't.
Is recommended, I think would give us some
Okay.
flexibility with.
That's perfect. I will take that.
I have a question. since you say when they present in your office, well, we are in the building 2 days in an elementary school, and so they're going to be presenting in a health room.
Yes.
With somebody who is not a nurse, and you've got PRN on there, and so it needs to be in layman terms. The PRN on there, it should be, because we will be delegating the medication to somebody who is not a nurse.
Okay.
There are very few buildings with nurses full-time in school districts.
Okay. Okay, so let's go ahead and move on because there's going to be time for questions, and I really want to give you guys an example on how to read it, okay? So red zone is the child is either past the yellow zone, you've given them 2 puffs twice and it's not working, or they appear immediately in distress. And so these are, again, what the severe symptoms look like in general. It could be any of them. It could be a constellation of them. It's just examples. And then what we want people to know is, especially if this child is not with you already, if this kid is in class, these kids are not to be left unattended. When I was making this form with our pulmonary specialist, they said these kids can pass out walking to the nurse's office. They can become hypoxic and they don't really know what's going on. And so this is, I don't know if a buddy system is best. It just says, don't leave the student unattended. They are not to be left to their own devices when they're struggling to breathe. They are the responsibility of us to take care of. And I don't know what that looks like or what that means, or if the teacher just walks the kid to the nurse's office or to the health office, but just don't leave the kids unattended. And then also, it says call 911 and or the parent per school policy. All of this is per school policy because it's not a one size fits all. Again, we know that there's not always nurses available and variable levels of comfort dealing with kids who are having an acute severe asthma exacerbation, and that some people require, once they're in the red zone or that they've required this much intervention, that they either go seek additional medical care or they have to go home and they can't stay on campus. And again, we can't account for all of the variability that exists within the different schools. So after you've determined, and you'll know your school policy, you're going to give the kid 4 puffs of the quick inhaler with the spacer immediately. And then you're going to wait. You're going to give them 20 minutes, see if their airways open up. And then if not, you can repeat the dose, giving no more than 12 puffs of the quick relief inhaler in 1 hour. And if that has not helped them, they need an emergency intervention because you've given them 12 puffs of albuterol within an hour and their airways have not opened up. That means there's something bigger going on. And then also, is that the kid who needs to be on campus with you at school? And then there are children who only need exercise pre-treatment and or for recess, and so we understand that as well. And so for the purpose of this form, it says no, but if they did, it would say yes right there, this dot. I think the whole trail it's supposed to follow is, I mean, if you're not the one presenting it. Okay. So exercise pre-treatment. If it says yes, it'll give you just the quick instructions on what to do. These are kids who know that they have exercise-induced asthma, and every time they're going to go exercise, they're going to have an asthma attack. So yes, they have pre-treatment, give them 2 puffs every 15 to 30 minutes prior to, and this is the part that will be variable for each kid, whether it's PE, recess, and sports, just PE, just recess, just sports, whether it's all 3. I would think it would typically be all 3. If it's 1, it's all. And then consistently, that says consistently, it can also say as needed. And so pre-treatment should not be given more than every 2 hours and may repeat 2 puffs of inhaler as the symptoms if they occur during activity. Let's get rid of the dot. Okay, so here's where we get into the asthma management with epinephrine, which was a big learning curve for me too. I didn't know that this existed until I got into the nitty-gritty of the form. Okay, so if it says, yes, they have a severe allergy, right here, and they attach the severe allergy form for you, meaning that they have an EpiPen, this is what the EpiPen information looks like, and how to use it, and what's going on, because of the severe allergy and the reactive airway disease and the component and how they fit together. What I just want to point out is that the important pieces here are the dose of the epi, and that all students given an EAI, which is the epinephrine auto-injector, must be monitored by a medical professional and may not remain at school. Those are the guidelines set forth by our allergy specialist here who created the initial pathway for our emergency department. These are children who need to have a medical specialist look at them, whether it's the school nurse or their parents, but it is not a lay person at the school. They have to be monitored by somebody who knows what to do, because we know epinephrine is temporary and it only blocks the symptoms short term, and so that there's a bigger underlying issue that needs to be taken care of. It's not safe for them to go back to class or stay at school if they've only just received albuterol, epi, and then they're done. All right, here we go. Let's practice real quick. This is Johnny. He's 6. He keeps coughing in class. The teacher knows that's one of his symptoms. He's having an asthma attack. Upon assessment, he's coughing. He's asking to use his inhaler, and per his asthma action plan, this is usually what he presents with. He's not having difficulty breathing. He's speaking in clear, full sentences, so he's okay. He's not proven himself capable of self-carrying his inhaler. So what zone is he in? Okay. Yellow zone, perfect. What medication does he need? Perfect. And how many puffs? With the spacer. Thank you, thank you. And now, when can he have an additional dose of his inhaler? Okay. And when do you advance him to the red zone? Okay, one person. Doesn't get better after the repeated dose. Perfect, yeah. And then when can he have a dose again if he's doing well now? 2 hours, yep. And
2 hours from the last test or the first?
yeah, from the last time he received it. And once he's in the red zone, what should you do? Yeah, 4 puffs, and then whatever your school policy is based upon. There's so many variables. Like I said, it really depends upon who's giving him the inhaler, what the relationship with the parent is like, how you know his asthma symptoms typically go. Oh, my yellow went crazy too. All right. And how many puffs should he get in the red zone? With the quick relief spacer. Yeah, and what's the total number of puffs you should give Johnny or any kid in an acute asthma exacerbation? Perfect. And I think when I did the math with the pulmonary specialist, I think it was almost 80 puffs that the kid was given in the one algorithm on the one form of 2 to 4 every 5 to 10, and rinse and repeat. Okay. After being in the red zone, should he go back to class? This one's kind of tricky because it's per your school policy, comfort level. Is the nurse on campus? How does the teacher feel? So we don't, per school policy, it's really open to comfort level. And does he cycle? Does he recover? How's his breathing? So you guys can pick. What? Right, so then I would say he probably should go home if you're not there to assess it, and if the parent-designated adult is not comfortable monitoring him.
Are we good?
Yeah, so,
Everyone's caught.
yeah, I just want to make sure you guys see this is the legal release, and I know one of the pieces of feedback I received from Nicole was that all this information just says nothing. But it doesn't say nothing. These are all of the RCW codes combined with the legal release for the parents to say that all of these highlights of the revised codes of Washington have been met and complied with within this form to give you guys the information you need to medicate these kids at school. All right, questions, go ahead.
Yes. Could we go back to the yellow zone, because I'm having a hard time understanding the second and third line about the instructions. Okay, so where it says, repeat after 20 minutes, quick relief inhaler in 1 hour. What does that mean? You give 2 puffs,
Sorry.
and then you wait 20 minutes and you give another 2 puffs, but then what does that mean in 1 hour? I mean, you can only have 4 puffs in an hour?
No, you can have up to 12 puffs in an hour. I don't understand what that typo is either.
It doesn't make sense.
Okay, I'll clarify.
Okay.
Thank you. Yeah.
Okay, and then where would you be addressing the ability to self-carry an inhaler?
There is an option. There is just a clear option that says this patient can self-carry their inhaler. And we know that only inhalers and EpiPens are available to be self-carried within schools per Washington state law. And it would be indicated, this patient can self-carry. Well, it's a combination of whether the family feels they can, if the school nurse feels they can. You guys have to sign off on them doing it as well. They have to be proven to effectively and accurately give themselves the medication, including the EpiPens.
Yeah. Nikki, what do you do in the case that like you're in the middle of like assessing between the yellow zone and red zone, like whether they're yellow zone going green or yellow zone going red, and it's the end of the school day and you don't have a nurse on staff and like there's no parent available and the kid's supposed to go home on the bus. Like worst case scenario.
Worst case scenario.
Yeah.
And you're not a nurse.
Yeah. Just call 911?
Okay. I would, if you can't put that kid on a bus in the middle of an asthma exacerbation without a family, that bus driver's not going to know what to do.
Okay.
So.
Hi, just a quick question back. This has to do with the ROI. And you said there's some flexibility with the dates. So if I know I'm going to have an elementary student for the next few years and I know it's a diabetic, so am I able to, because I will initiate the Seattle Children's Forum with the family. Mm-hmm. Can I write in there several school years?
Yes, it just has to be a finite date and it's not good
Right.
for more than one school. Yep.
You're right, that would be awesome.
Yep.
Thank you.
Yep.
We are going to take one more question, and then I have a couple closing comments and questions for you guys. I saw a few hands.
So when are these forms going to be filled out? When are these forms going to be completed? You know, like when can we get the 1920 school year forms? Like, can we sit our teenagers down in June and print them all out and get parent signatures
Absolutely.
in June? Because they'll be filled out in June.
They are available as soon as they ask for them. Our problem is always in that people come in August and September within 2 weeks and want the forms to be returned to them immediately, and that's not possible. They can come whenever they want for that following school year. Sure. Yeah. I mean, sure, it's up to the provider if they want to sign off on that, because then that means that they won't be seen again within that entire school year if they have validated orders. But they're going to need a refill. So even if they have valid medication orders for you, they won't have medication unless they come back. So those things need to co-occur.
We'll do one more question. Nikki's going to stay up here for a few more minutes, and then we'll close a few things.
I'm running.
My question is there a spot on the form for doctor's signature? Because if I'm taking this as an authorization, where's the doctor signing off on this?
The doctor does sign it. It's signed electronically by the provider and by the nurse, and by the family will hand sign it. So this is the pulmonary provider's information would go underneath the family's information, and it would all be electronic right here.
Okay.
I just didn't put it on because I didn't have a provider to sign it because this was a make-believe patient.
Okay.
Can I remind everyone that there's a snow gathering at 4:30 at the Ram at the U Village?
Wow.
Wow. Yeah, snacks
Do they know how
provided.
many? Okay, so we've reached the end. We want to say thank you to Nikki.